COPD is one of the leading causes of disability and mortality worldwide. Its prevalence is highest in Caucasians, and it's more prevalent in women than in men. COPD is typically not diagnosed until after the age of 60, where the decline in respiratory function creates a set of chronic symptoms, including dyspnea or shortness of breath, wheeze, increased mucus production. Patients with COPD are some of the highest utilizers of emergency room and inpatient acute care. The exacerbations of COPD are associated with a decreased quality of life, increasing severity of chronic conditions, risks for nosocomial infections or hospital infections, increased mortality. For these reasons, the prevention of exacerbations of COPD should be considered the main goal of care. In order to do so, early treatment and prevention of exacerbation is key. COPD is often considered a blending of a few different chronic conditions, including emphysema, chronic bronchitis, and asthma. COPD is a chronic state of limitations in airflow during respiration and is associated with a state of chronic progressive inflammation of the lung passages. Symptoms of COPD include airway obstruction, increased mucus production, decreased activity of the cilia, which help move the mucus, reduced gas exchange, dyspnea, wheeze, and cough. Anxiety and depression are often comorbid conditions related to the increasing in severity of shortness of breath and the symptoms associated with it. Although COPD is mainly associated with the respiratory system, so too does it affect multiple systems of the body. In the cardiovascular system, gas exchange abnormalities occurs, which often results in acute states of hypoxemia and hypercapnia. Pulmonary hypertension requires increased cardiac force, which can promote cardiac hypertrophy and right ventricular dysfunction. COPD places people at increased risks of cardiovascular disease, including arrhythmia, myocardial infarction, chronic heart failure, stroke, and pulmonary embolism. Increased cardiovascular disease is actually seen under the age of 65 and often in those with COPD. Regardless of age, the risk for dysrhythmia, which can occur from hypoxemia, creates an increased risk for venous stasis, which also increases the risk for thrombosis, directly leading to the risk for stroke. The body overproduces red blood cells in response to chronic states of hypoxia. Polycythemia, or increased red blood cells, also creates an increased risk for blood clot, stroke, or myocardial infarction. In addition to the respiratory symptoms noted earlier in this presentation, normal age-related changes can quickly hasten the progression of COPD. Respiratory muscles weaken and the rib cage begins to stiffen. The elasticity of the lungs decline and the size and degree of opening of the most distant bronchioles decreases, leading to a reduction in the inspiratory capacity of the lungs, and the amount of air that remains in the lung with exhale increases, leading to decreased diffusion and oxygenation of the blood. The body's response to increasing carbon dioxide level decreases with advancing age as well. Longer periods of time of exposure to pollutants and cigarette smoke can further affect the mobility of the cilia, increasing mucus production. Although changes in the endocrine system are associated with COPD, the mechanism by which this occurs is not fully understood. Chronic hypoxia and hypercapnia may contribute to the way in which COPD leads to changes in the pituitary, thyroid, the gonads, the adrenals, and the pancreas. Corticosteroid therapy, such as prednisone or fluticasone, may also contribute. Systemic inflammation may cause changes in the pituitary production of growth hormone, contributing to muscle wasting and weight loss. Oftentimes, end-stage COPD patients do assume a specific body posture. Musculoskeletal changes in COPD are common. Increased accessory muscle use contributes to rib cage stiffness. The forward head posture in response to dyspnea opens the upper airways and reduces shortness of breath. These continual postural changes may be associated with the eventual reduction in thoracic rotation. Skeletal muscles may become hypersensitive to chronic inflammatory states, causing increased pain, especially in the spine and neck. Gastrointestinal changes are common as well. Chronic states of shortness of breath, increased mucus production, and fatigue are often associated with impaired nutritional status, often associated with decreased body mass index and worse prognosis for the disease state. With a diagnosis of COPD, multiple risk factors may contribute to its severity. Modifiable factors may include the episodes of acute care. When a patient has more than 3 hospitalizations in 1 year, it increases the risk for future readmissions, leading to the worsening of symptoms and a reduction in lung function. Under prescription of long-term oxygen use increases the risk of admission as well. Oxygen use has been shown to be associated with longer survival. Poor compliance to oxygen therapy and long-term medications increases the likelihood of exacerbation and ultimately hospitalizations, further contributing to the severity and the progression of the disease. A lower FEV1 increases the risk for readmission as well, as this indicates lower lung functioning and possibly less response to bronchodilators. Increased physical activity improves the body's capacity for exercise. It improves muscle function, decreases fatigue and dyspnea. It also increases independence and quality of life. And of course, exposure to air pollution and smoking may contribute to the severity of the disease. Non-modifiable risk factors for COPD would include gender and age. Women of Caucasian origin are shown to have increased prevalence for COPD. Women show increased dyspnea and lower BMI for a given FEV1 and age range, suggesting a worse prognosis for the disease and increasing the risk for mortality and hospitalization. Additionally, women are more likely to exhibit anxiety, suggesting a need for specific assessments, individualized care plans, and a medication regime that fits. The normal physiological changes in age-related in respiratory system exacerbate COPD symptoms and the progression of the disease. The nursing care is key to a COPDer's longitudinal plan of care. The nurse must assess for barriers to receiving appropriate care, including transportation concerns, which may ultimately affect the amount of appointments the patients can get to. Their adherence to the recommended plan of care, including oxygen and medications, and need for changes in their lifestyle, including smoking cessation. Financial concerns should be assessed for, including insurance coverage or lack of, as multiple medications may have quite a hefty copay. The patient's level of independence and self-efficacy may ultimately either contribute or decline the ability to take care of themselves and increase the need for assistance. There also may be comorbid conditions that must be assessed and addressed, including depression and anxiety. COPD patients benefit from continued education, including self-management action plans and zone tools, which may help to define symptoms and when to call the clinic. Symptom monitoring and reporting through telehealth or home health agencies can also contribute to a patient's health. Continued education on smoking cessation may be a long process. The coordination of care exists. Rehabilitative services have shown beneficial for COPD patients. Pulmonary rehab helps to relieve shortness of breath and improves the control of symptoms. Home health may provide early assessment, early treatment, helping to reduce the exacerbations which may lead to acute care. Physical therapy promotes chest wall flexibility in the thoracic region and may be useful in managing shortness of breath. When treating COPD, a close connection with a primary care provider for the early management of COPD symptoms through action plans and being actively managed by a primary care team rather than a pulmonologist decreases the risk for acute exacerbation and hospitalization. Diagnostics may include oximetry studies, complete blood counts, arterial blood gas, chest x-rays, CAT scans, and a PFT, or a pulmonary function test. Typically, these PFTs are seen as the true diagnostic test for COPD and shows how well the lungs are able to move air during inspiration and expiration. An abnormal PFT indicates blockages of the airway, or air trapping, and helps to show the effectiveness of certain inhaled medications. Supplemental oxygen, bronchodilators, inhaled corticosteroids, oral steroids, and antibiotics all may be used in the treatment of COPD and its associated symptoms. Technological advancements contribute to the care for COPD patients. Through the comfort of their own home, patients can have vital signs monitored through telehealth systems and oximetry studies completed. BiPAP and CPAP settings can actually be completely wirelessly reset, and the device may monitor their oxygen levels overnight. Patient portals for electronic medical records and messaging systems make staying connected with the primary care team much easier. Appointment reminders may help patients to be adherent to their plans of care. As demonstrated earlier, so much of the progression and severity of COPD is related to acute exacerbations of symptoms and the associated decline in lung functioning. As such, when creating the concept map, the end result of treatment is not eliminating the disease, but rather decreasing the amount of exacerbations. As is the case with so many chronic conditions, COPD is an ebb and flow in severity of a long-term disease that benefits from early and continued treatment and coordination of care.